Srikumar Vasudevan sir did his MBBS from SPV Government Medical College, Cuttack, Odisha, and post-graduation MD from AFMC, Pune. Srikumar sir was the state president of IMA Kerala during 2009 period. Currently, Srikumar sir holding the post of convener National IMA Ethics Committee. He is National Faculty of UNESCO Bioethics, and also sir is chairman of PP scheme and legal cell of IMA case. With this word, I invite Dr. Srikumar Vasudevan sir of the stage.
Respected branch president, Dr. Suresh, and all the senior leaders assembled here, and my dear friends. Today's topic is breaking bad news, an art or a craft. You'll all agree with me that breaking bad news is one of the most difficult process which any practicing clinician would have faced. And unfortunately, I can say that though all those practicing clinicians would have at least faced once or may have faced repeatedly situations where they had to break bad news. But unfortunately, we had no formal training of how to break bad news in our curriculum. So it is, so many a times, this is one of the main reasons why people react violently or react in a way that we sometimes wonder why they are reacting in this way. We've been talking about violence against doctors, violence against medical professions. It is because not only doctors, even the nursing staff, how they behave. Sometimes it's because we are not being told how to behave, or because they, apart from, it's always said that medicine is science, but practice of medicine is an art. So we've been always trained to, the training which we get in medical colleges are mainly to improve our skills, our proficiency in our skills, but never are we taught about communication skills. I think communication skill is absolutely necessary for doctors, at least in this present era. It was possible long ago, but now we see on a daily basis we have some problem or that somewhere in our state. One reason is because of lack of communication skills. Even we do everything for the patient, but the way we communicate is sometimes the biggest problem or the reason for the, not always, for the reason that we face a lot of violence or other sort of pressures which we face during patient care. So what is actually bad news? Robert Buckman, he is a British oncologist who was working in Canada. He says that any news that drastically and negatively alters the views of his or her future is said to be a bad news. And it's always said that truth can be brutal, but the telling of it need not be. So that is actually, that is the bottom line of how to communicate bad news. So, and I'm just enumerating a few of the bad news. This is not the only bad news. There are lots and lots of bad news, but I just highlight a few. Diagnosis of malignancy. When you have to tell a patient that he's having malignancy, it's quite a difficult job. Or when there is a recurrence, you have treated him and there is, you feel satisfied. Suddenly you find there is a recurrence. You have to tell the patient. Or there is a failure of treatment. Any sort of treatment, you find it's difficult. It may be tuberculosis. It may be even any other problem. There is a failure and unexpected complications. I think every specialty would be having this problem And everyone, that is why I said everyone would have faced this problem repeatedly, where you have to communicate to them and tell them that this was this because of this and all that. Even despite your best efforts, sometimes some complications come up and you have it. Miscarriage or infertility is, I think, the gynecologist always, we always say that in PPC, gynecologist maximum number of litigation because they deal with two lives. And many a time it is this miscarriage or even infertility treatment, failure of infertility treatment and all that, loss of eyesight, loss of sight. But sir is there, he can vouch for it. It is a big problem. Amputations, and even a 9-year-old child who, if you are going to tell him that he's having juvenile diabetes, it's such a tough job to convince his parents. And the most dreaded of the whole lot is death. When you have to communicate death, especially when it is an unexpected death. This communicating our bad news is quite stressful, especially if the patient is very young or if there is limited prospect of a successful treatment. And as far as the doctor is concerned, it becomes more difficult. An experienced doctor finds it much more easier to communicate bad news. But whereas a young doctor, a doctor who is just passed out or who's hardly not very much experienced, he finds it a lot of things. Sometimes the doctor feels that he's taking away hope from the patient. So he feels it bad to communicate. And suppose there is, very often one reason is they are scared of how the patients or the relatives are going to react. Everyone is scared because that nowadays people take law into the hand. They're scared how they're going to be, and over that they are now wondering how they are going to react to this, the way the patient, suppose the patient gets angry or the patient gets violent. How am I going to face this problem? You saw that unfortunate, the doctor who committed suicide. She was scared. She didn't know how to react, and that is why she took her life. And another thing is the busy schedule. You are a busy. Suppose you are a busy surgeon. You have a surgery just coming, and suddenly you see that a patient is having a malignancy. You have diagnosed a malignancy. You don't have the time, or there is some other gynecologist who have a cesarean pending there, waiting for you. And here you have some other complication. You have to tell the patient the procedure which I am going to tell you of how to break bad news. I think it is quite difficult for them in a busy schedule. Anyway, breaking bad news is a complex communication task, and it has got a verbal component. That is what exactly you are going to tell. That is there is a major part of the talk when you're going to tell. This is this you're going to. But along with it, you require other skills, like you have how you will respond to the emotions of the patients or the relatives. How you have, suppose it's a malignancy, how you're going to make the patient a part of the decision making. You have a lot of decisions you have to take, or you want the patient to be undergo a surgery. You have to convince them. The old method of paternalistic attitude cannot be tolerated now. People don't agree. That paternalistic, that is the father and the son relationship, where the father says, the son listens. But that attitude cannot go now. It is called the autonomy. In medical ethics, the 4 pillars of medical ethics. One is autonomy. The other one is beneficence. That you will do good to the patients, non-maleficence. You will do no harm to the patient. Justice. So these are the 4 pillars of that. And one of the most important things is autonomy. So with autonomy, whenever you take any decision regarding the patient care, the patient should be made a part of the decision making. So when you're going to go for treat for a malignancy or any other ailment, it is your responsibility to make them a part of the decision. So you are scared of how the patient is going to react. Dealing with the stress created by sometimes the patients have a high expectations. He is going to get cured. In your heart of hearts that the prognosis is bad. But patients have so much of faith or so much of hope that you find it very quite stressful to tell them. And as you know, multiple family members. Some of them are buying colloquial language. We say that chorian complete. Patient. We tell that. So these are the way we have to handle them. And as I said, the situation is bleak, but you have to give them hope. Otherwise, they're not going to treat. So these are the things that we have to face when breaking bad news. There are different ways of breaking. There are different models, but the most prevalent or the most commonly followed model is the spikes model. Can anyone tell me? Are you aware of the spikes model? Anyone? Yes. No, none of us are aware. That is a very important. See, it's called the spikes model. SPIKES. Spikes model. So these are things which we should be knowing, because we have been, as I said, we've been all dealing with such situations, but we are not aware of the spikes model. So spikes, S stands for setting up the interview. So when you want to tell the patient what you should be mentally and physically prepared to tell the patient what you want to say. So when you're going to say, you should be prepared of why, what, when, where to say. You should be ready for it. You should have all the documents, everything you should have it within you. You must be well studied about all the things about that disease or the complication, not theoretical on every aspect. What you have done for the patient, everything should be there with you to prove the patient that you have done best for the patient. And you have to use the correct vocabularies. I think we'll go there. Mental rehearsal. Before you go, you should be mentally rehearsing yourself. Yes, this is what I'm going to do. I think as a child, I always had this training. Whenever I used to get my report card, I had to go to my father. I had to rehearse myself what all excuses I'll give before he signs. I think I have faced this. I don't know how many of you have faced, but I have. I have always faced when I go home. I keep going every Saturday somewhere before I have meetings. I have to find some excuses of how I'll go out, tell my wife. So these are things which we rehearse in our mind. Yes, I'm going to tell this. So I am confident I might tell the truth, I might not tell the truth, but these are things where you have to rehearse yourself, mentally prepare yourself and go and speak to the patient. And physical preparation it's always preferable to speak to the patient in a separate room. But every time you will not have this privilege. The situation in which, suppose, especially in government hospitals, you can't ask for a separate room to speak. You will have to speak there. So in front of all patients, it is difficult. So you can at least, suppose in the ward, you can put a screen around and tell, because the emotional outburst which the patient is going to have, all these things can be to a certain way curtailed by putting curtains or some sort of restrictions and making connection with the patient. Always when you are talking to the patient, you're going to break the news, make it a point to sit down. The very fact that you sit down, it relaxes both you and the patient. Whenever you sit down and talk, you stand and the patient sits, it's like it's called a domineering feeling. The patient feels that you are trying to dictate terms. You sit down with the patient at the same level, and then when you sit, don't cross your legs, sit the legs apart with your hands on your thighs and look at the patient. Eye contact is very, very important. And maximize privacy. Maximize privacy. Don't, as I said, don't allow people to be there, and avoid interruptions. You shouldn't have a TV in your room, or you can tell the patients, tell your nursing staff, please for 10 minutes, don't disturb me. You can ask the patient to switch off their mobile so that interruption is not there. And involving family members. You don't have to group all their family. At least even the patient feels comfortable when one or two family members come with them. So you can ask them, you can invite them. Okay, you bring one of your relatives, you bring your friend, and then you can break the news. So this is the setting up of the interview. See, this is just a picture which I said, the way he's sitting, the touching them. These are called, that is in communication skill. That is called the soften technique. Where soften technique stands for S stands for smile, O stands for open posture, F stands for forward lean, T for touch, I for eye contact, and N for nod. So that is called the soften technique. At least here we find it very difficult to smile. Can anyone tell me what is full form of smile? Selling maximum, incurring least expenditure. So that is what the salesman taught. Selling maximum, incurring least expense. That is smile. So these are all, there are different techniques. I'm not going to that. And you use the soften technique. And then next is the P, that was the perception. Before you go to deliver the bad news, you should know exactly how much he knows. You should know how much he knows. Then only we should. It has got various advantages why we should know how much he knows. For the first reason that nowadays people have a lot of internets. People have there are a different type of patients come. They might have read something, so they have a wrong idea or wrong perception of the situation. They may be misinformed. Or you should know what level of they know about the matter. Number two, while you talk to them, while they talk to you, you will know the emotional, what is their emotional level, the tone they use, the words they use, whether they are angry, whether they're sad, the body language which they have. All this gives you an idea of what is in their mind, so that you can tailor your talk according to the emotions or what is in the mind of the patient. And if it's a known patient, suppose you are following up a patient, the patient comes to you with a swelling, and then you have done a scan for the patient, you have done a FNAC, then you have done all radiological investigation, finally you've done a biopsy, and you get the histopathological report. You have been repeatedly coming in contact with the patient, so you know it. Sometimes what happens, someone else has done all the investigation, the patient is sent to you. That is the first time you're meeting. How do you deliver that? So that is the difference between a known patient and an unknown new patient. And as I said, internet, that's what I said. People are all nowadays they Google everything and find out before they come to you. So very often behave as if they know more than you. Even they come out with the various treatment protocols. Some of them, not all, but that you have to handle them. You shouldn't get irritated. Sometimes we get irritated because they talk things which are foolish, but they behave as if they know everything. So these are things which we have to be careful. That is the perception. Then as I said, these are things which I already said: the style, emotion, tone of the voice. Another important thing with this, once you know where what they have, one important thing is informed consent. So you have to go for a procedure, you have to go for a surgery following this, you know where they stand. So how much information you have to give them for the informed consent is very important. So you get an idea of what you have to say. So perception is the second part. Then coming to I, that is invite the patient. So here, how much the patient wants to know is what you have to know. See, you have set the interview, you have understood how much the patient, now how much the usually patient wants to know everything about his ailment, usually. And all the different modalities of treatment, everything they would like to know. But there are some people, so it becomes easier for the concerned doctor to tell. But sometimes the patients, they just don't want to know. They just say, doctor, that becomes a problem. That is where you have to take the decision. You can't make them a part of the decision making, and they don't want to. They are just stonewalling you. They just don't want your interest. But in a way that is good. In a way that is good is because it is actually shunning away of information. It's called shunning away of information. Shunning away of information is a way how they take away their tension. They're not just, they don't want to be tense. So that helps you in your treatment in a way. But then there is, as I said about this thing, autonomy. Autonomy, as I said, is making them a part of it. And one of the most important component of autonomy is informed consent. This informed consent, I think you all know that it came from the Nuremberg Code of Ethics, which followed the Nazis. The atrocities they did on the prisoners of war, and that led to the informed consent. So informed consent, before you do anything, before you put your knife, you have to inform them. This consent is a huge topic, one day's topic. So I'm not going to the thing. So informed consent, you have to inform everyone. But at the same time, autonomy is this, according to his autonomy, he doesn't want to know anything. So it's a contradicting things. This is one of the areas where informed consent and autonomy is contradicting each other. So you have a lot of problem. Anyway, you have to talk to the patient and find out how much he wants to know. Now, then comes the K, that is the knowledge. This is what is the most important component of the spikes protocol. This is where what you're going to tell the patient about. For that, as I said beforehand, you should be well prepared. You should be mentally, physically, all that is done. You should be prepared of what you're going to say. You should have all the papers, documents to tell what to the patients. You should be thorough with everything which you're going to say. This is very important. So they may ask you questions. You should be ready for that also. You know what is confidence? I think people, if you tell me, do you know what confidence is? Confidence is not knowing answers for all the questions. Confidence is willing to answer any question. See, Tendulkar is a confident batsman, means he is willing to, he doesn't know which ball is going to come. He is willing to face any ball. So that willingness is there. So you should be confident enough. You should be prepared enough to talk to when the patient is. You should not start worrying about what the patient is going to ask or what. Don't. You should be there. And the 4 important things which you will be discussing is diagnosis, treatment plan, prognosis, the support things which you have to do. And now you already, as I said, you have perceived how much he knows. You have understood how much he wants to know. So you have to tailor your words, as I said, your tone, and tell things in a manner which he doesn't get offended, or you can develop that interest in. So this is the most important aspect, and that is part. These are things which I cannot just tell you. It is just our experience, and that is why I said in our medical schools we are not taught. We are not taught. We don't see how our seniors or how our teachers will be breaking bad news. I think this should be an art. It should be something taught in our curriculum, where when we are house citizens, we should be looking at what the teacher is telling and how he is breaking the bad news. We usually don't do it. We run away. But I think these are things which should be given a lot of importance if we really want to prevent these attacks. Expectation, we generally we as doctors already we feel that they should accept whatever we say, whatever advice we give, they should accept. We really believe that, and we also we feel that whenever we tell some bad news, they should not get upset. We generally think that what is the harm, because we are so used to seeing these things, we don't feel bad. But a layman, when you talk about death or you talk about a very serious illness, he feels really perturbed, and and we feel quite optimistic. Okay, this is you will do the surgery, everything will be fine and all that. But the reality is something different. They will not accept. You should not get irritated, or you should not get angry when they are not going to listen to you, or they don't accept your treatment, or they even reject your treatment, or they react to the news in a way which you never expect. So these are things which you should be preempting and modulating your behavior, your words accordingly. And how do you convey? It's like aligning. When you say aligning is like railway track, you see a track coming onto the main line. So that is the way you come from the side and enter. How do you track? You have listened to what he knows. You start from there. Initially you tell him, yes, whatever you are telling is correct. This point was correct. This is that. But you also know that he has certain misconceptions. Slowly you go to the misconception. First you agree with him. These are the points which he agrees, what is right. You start agreeing with him, get his confidence, and then slowly try to say whatever he feels is wrong, whatever you feel, yes. You slowly bring in scientific evidences to prove that he is wrong, and slowly change his thinking so that he accepts whatever you say. So these are things which you should be doing slowly. And when you speak, you should not, when you speak something bad news, it's always very important that you, as I said, eye contact is very, very important. Eye contact is very important. And whenever you break, suppose not only in this, you want to talk to someone, you have a problem with a person, don't talk over the phone. Even if it's your wife, don't talk over the phone, because only 8% of the 100% is verbal. That is whatever you speak. 37% is the tone which you speak. And 55% is your body language, the way you're speaking, the way you talk. So that 55% is cut off if you speak on the phone. So whenever you speak to the patient, look at his face, look, as I said, the soften technique, and then speak. So it brings about a lot of change in how you deliver what you want to say. And there are certain points which he is told wrong, and you start slowly reinforcing this point, push so that it stays in his mind. And sometimes the warning shot, when you're going into the bad thing, you can just use such sentences like the situation does appear to be serious, or unfortunately I have some bad news to tell you, or I'm sorry to tell you, or things are not going in the direction we had hoped. So these are things we slowly, when you start telling the bad news, you can start with these sentences. And try to stop using medical jargons. I think that is a very important. When you speak, try to speak the colloquial language. Try to speak the most simplest of language. Don't tell metastasis, which is spread. Or certainly there are so many. I have heard people telling, but colostomy won't do very. See, the patient doesn't know what is colostomy. You should tell him in simple language so that he understands what is colostomy. And don't tell it in a way that he gets scared. Don't tell all that. He gets scared. But that is the way you slowly tell him. And you say colostomy one, he tracheostomy one. So you tell him tracheostomy one, he will not understand. So these are medical jargons which you and I will understand, but not a layman. So when you say that, we have to be you should not be blunt. Sometimes some doctors are very blunt. They just say, this malignance a prashna hai. You just tell the patient, the cancer problem. So the fellow, he half this thing is gone. Suppose someone tells you, one patient came and told me that one of my relatives, he went to a doctor. He was, for the first time, he was diagnosed having diabetes. But doctor this has happened. You see, that the patient, that your relative of mine, when till he died, he was always telling, doctor so these are things which we should not be telling. So we should be very careful when we tell. So check periodically what the patient is understanding. When you're telling, see, sometimes they will be having a blank expression because they are scared. They are thinking of so many other things. So you should wake them up by asking some leading question, whether they are understanding what you're saying. Tell things, ask them certain things so that they'll come back. Sometimes they just, in a class, when the teacher starts, we start thinking of something else. So the minute that the teacher asks a question, we are all alert. So similarly, we have to tell the patient also, ask him some questions just to bring him back. You can make out from his, see, I had always thought that I was very smart in my class. My teacher was, I am very attentive. I used to feel that the teacher, I was not attentive, but I used to feel that teacher would never make out. But when I started giving talks, I realized that standing here, I'll know who is attentive, who is not attentive. So these are things which we develop. So you can easily make out what the person is thinking. So to bring him back, you should ask him some questions so that, did you understand or did you? So you ask him some question, he'll come back. So these are things which you should be doing. And avoid things like there's nothing we can do. We'll try a thing. These are things we have to do. And sometimes you have to listen to them. They are shocked, totally shocked. They have many things. You are talking about malignancy. You are talking about chemotherapy. The patient is more wonder. He'll ask you, doctor, chemotherapy. He knows. Then he is thinking about that, or she is thinking about that. How she will look with all her hair lost. So these are things that are more worrying. Sometimes the man, he's saved all his savings for his daughter's marriage. His daughter's marriage is in another 3 months, and now you say that he is having malignancy. You have to go undergo surgery. You have to go chemotherapy. You have to go radiotherapy. He's now more worried about his daughter's marriage, not about his ailment. So you have to convince him. You have to tell him, in such a way that he listens to you. So that is why I said, he thinks of so many things which you don't be thinking. You will be just don't tell in a single, or tone. You should tell it in a way so that they listen to you. And next is the most dreadful thing, that is the empathy. How they are going to react. Empathy, I think, sympathy you all know. You all know sympathy. But empathy means putting yourself in that place. So you should always empathize with patients. You should always think, if I was in this position, how would we have reacted? I always, when I go to talk to the nursing staffs, sometimes they call me. First thing I tell them, you should be empathetic, because the nurses are the most people who are always in touch, in contact with the patient. They have to be empathetic. It's not only sympathetic, empathetic. You should, you feel, they should feel that yes, you are a part of them. Our mother will be empathetic to us, not only sympathetic. Everyone, I think how much ever we do, our mothers will be empathetic to us. So that is the way we should be reacting. How violent they may be, how we should listen to them and try to react. They should be, their reactions may be different. Sometimes some of them will be just silent. They will not. They'll just keep quiet. Some of them will start crying, sobbing. Some of them will cry loudly. Some of them will be banging on their chest, and some may even scold you, angry. Sometimes they might even go to be violent. So this is the different range of reactions that a patient can have, and you should be knowing how to handle each situation. So that is the most, as I said, the most difficult part of breaking bad news is not only breaking, how they are going to react and how we are going to react to their reactions. So that scare, we what we do is we ask someone else, don't do that. Because if a patient has come to a surgeon or a gynecologist, he's come because he has faith in that doctor. Whatever problem he wants to listen from the mouth of that doctor. Whatever may have happened, you send a X person or a third person, he is not satisfied. That is when he feels that the doctor is hiding something. If that same doctor comes to him and tells him, he will understand. Because that faith, doctor-patient relation is based on faith. Because he's giving a life to you, so he has that faith to you. So you should show the same faith that you should believe in that patient. He's not going to be violent, and go with that confidence. As I said, confidence means you're ready to accept any ball which comes. I'm ready to face. That is confidence. So you should be going with that confidence that the patient will not abuse me or will not be violent with me, and you will see to a large extent that you can do it. But don't push it to someone else. Very, very often this does. He'll tell the anesthetist, the surgeon will not go, or the gynecologist will not go. You go, let the anesthetist come. The anesthetist may be having the gift of the gab. He knows how to speak. Fine, but let him come with you. But you should go. You should not stay back. And sometimes, the patient will be just silent. Just so don't keep poking him and telling him, just keep quiet. You also keep silent. Listen to him. He's that news, that bad news. So he is slowly sinking into his mind. Give him time to let that bad news sink into his mind. And then only you should slowly, as I said, all the techniques which I said, slowly inform him. And do not agree or criticize him. This has happened. You will not believe that one patient, his mother was brought dead to the hospital, and the doctor, the son came running after some time. He was here. He was somewhere else. He didn't. The mother was sick for some days, and he was not there. Anyway, he rushed up. He came to the hospital after the mother's death. So this doctor abused him. He criticized him. He told him, so this fellow, he kept quiet. He didn't tell anything. He was feeling guilty. But later, he went outside. This doctor didn't leave. He went outside and started again telling him, "Nee endur magananu and all." That fellow he gave him one slap. Indinte avashyam? Why do you want to go and poke him? You have told him once, fine. So this is the way you start unnecessarily inviting problem. Don't criticize him or don't fire. He may have, see, as when our own child, sometimes our own child, they just get angry and tell you. You don't spank them at once. You listen to them. And you keep quiet. After some time, he'll cool down. Similarly, everyone, when they hear a bad news, even you get angry. Sometimes your wife tells something, you get angry. But you don't at once do anything. You just keep quiet. After some time, you cool down. Similarly, it's any bad news, anything which irritates you, they are bound to react in different ways. It's our duty to responsibility to see that and thing. You have to accept that a death has occurred or something has happened which you are also a part of that treatment protocol, and there is certain amount of responsibility on your part. As I said, this is just an example. The doctor says, I'm sorry that the CT scan shows that the chemotherapy doesn't seem to be working. The patient is crying. I'm afraid of this. And then the doctor will pull his chair close by, touch his hands or his shoulder and tell him, don't worry, we'll do something. That is sympathize. You empathize with the patient. And the last one of these spikes protocol is the strategy. To establish what the patient have for the next future, whether it is malignancy, whether it is infertility treatment, the patient has spent lots of lakhs of rupees, and still they don't have the lady has not conceived. What is your future plans? Or you just don't blurt outside and tell namakku karyam cheya ende aduthu undu I will put it in your wife's system. So you should not do that. You should not tell that. This has happened. Whatever I am telling, these things which out of my experience, which patients have come and told me that infertility specialist said that we have got fertilized egg here, we will put it there. This is not function. So don't worry, who will know? So that is not why you tell them all these things. They are already sad that they didn't have the mother did that, the lady didn't conceive. They spent lakhs of rupees and then didn't conceive. And you just coolly say that, see, you are being unsympathetic with them. You should be, that's why you should be very careful when you say things. And before discussing, you should all the modalities of treatment, you have to tell them what treatment you can take. So that is again what I'm saying of informed consent. Informed consent in yes. Informed consent, one important aspect is the patient has a right to reject your treatment. That is informed consent. So consent to informed consent is the vyatyasadana. Consent. But informed consent is that the patient has a right to reject. That's a very important aspect of informed consent. Varum patient inform. Informed consent, the patient inform our consent. No. Informed consent has got this extra thing, that is, he can say, no, I don't want your treatment. I don't want this modality of treatment. I'll take this treatment. So these are things which you should understand. Presenting treatment options, sharing the responsibility of decision making, and checking the patient's misunderstanding. I think I've told about all this. When the prognosis are unfavorable, you have to tell them. That becomes all the more difficult when it's unfavorable. Sometimes you must have told the patient, suppose everything is fine. Thyroid swelling. Suddenly you find that it's malignant. Then you are embarrassed. You have been telling, the patient has been under your treatment for a long time, and suddenly you have diagnosed it, or she has gone to some other one and someone else has done an FNAC recently. You have done it maybe 1 year or 2 years back, and now they have done an FNAC, or they did a surgery, and then after biopsy it has come out as malignancy. Then you are embarrassed because you have been telling the patient for the last 3 years or 4 years that nothing, don't worry. So these are situations where we have to be very careful. And the most dreaded of the whole lot is dealing with death. I think that is something which I just pray that no one has this option, especially if it's an unexpected death. Expected death, we can understand. We can tell the patient is also accepting, okay, the patient is bedridden and he dies. Even sometimes the relatives are happy. Yes, okay. And even these people who are looking after also feels, okay, but if it is an unexpected death, it is following a pregnancy, following a cesarean section, either the baby or the mother dies. It is a moment of joy in there, and not only with the father and mother, it's for the entire family when a new arrival comes. But then you are suddenly told the mother is not there. So and it is the responsibility of the gynecologist to go and convey this message. I think that's the most dreaded. I always feel that it becomes a dreaded thing. Malignancy, it's okay, but death is something which, whatever be it, unexpected death is something. A patient has come for or appendectomy, some anesthesia complication, and the patient dies, and you have to tell that parent that the young boy of 16 years who has come to you and he has a bright future, and suddenly the patient is no more. So these are things you can't believe. You can't. Something which is how much our training or spikes protocol is there. It is a very difficult. I just pray that no one has this experience of conveying death. And it's highly stressful, as I said. And as I said, expected death is better, but unexpected death is it's a big problem to convey. You need special skills to do it. And possible reactions, as I said, it's more shocking. It's the intense. It will be more intense. It can be violent. Mostly it is violent, especially unexpected. It is not only the relatives. The police just troops in. As soon as this is nowadays it's a norm. As soon as there is an unexpected death, the police comes rushing into your thing and snatches away the case sheet and goes off. And you have not returned the case sheets. The patient initially there may be total shock. They can't believe. Then they're shocked. There is a denial. No, it cannot happen. My son cannot die. My father cannot die. My wife cannot die. And then there will be anger. And sometimes they will be guilt. As I said, incident, he guilty. That fellow was feeling guilty that he didn't bring his mother before. He was feeling guilty. Doctor, so he was feeling guilty. He kept quiet. But then after that fellow was going outside, he went outside and again fired. I asked that doctor, why did you do it? So when that fellow is feeling guilty, you go and he'll react. And the onus of convincing the bereaved family depends entirely on you. And so suppose there is an accident and a patient has been brought to you, and the family members are not there. It is your responsibility. A senior doctor calls up the people and tells that your patient is sick, your patient is serious. Please do come to the ICU. You have to come. But never ever tell that the patient is dead. Over the phone, as I said, don't break bad news over the phone. Don't tell the patient or something. You tell that the patient is serious. The patient is in a very serious condition. Please come to the ICU. We are this hospital. We are doing our best to save him, but we require your presence. They will come rushing. They always have that hope that my son is still alive. But don't tell him and say, I'm very sorry to inform that don't do that. There will be certain situations. Suppose someone is outside in the Gulf or something, you are here. You can't say, you can say that again, he's serious. Please call back after half an hour. Slowly, you break the news. By then, some relative would have gone and broken the news. So always, even I'm not talking about this, even as a doctor, even just as a friend or a layman, he finds it very difficult to convey the death of his relative or his friend to his parents. Isn't it? I think you'll agree with me. So these are things which is very difficult, and we should refrain from, and we should ask the patient. Once that relative comes to the, when you should be telling someone, to not the security of the hospital, patient or relative on the air ICU. No, you should be giving some responsible nursing staff to just tell them, come, bring them out. Not then, not the security. No, I think you should respect them. You should make them feel that you're concerned, you're bothered. You are also grieving with them. You are also in grief. That is the message you convey. And take them to a furnished, comfortable room. And this, I always say, when you're going to break bad news regarding death, that room, you should be very careful. You should not have TV, or you should not have any expensive things. You should have heavy furniture. Because they'll use it as a weapon. I'm not joking. They use it as a weapon. This has happened. So it should be heavy furniture. These are things which we should be very ICU at the room in a one. Sometimes to tell that. They use that chair at the teddy or they use flower vase. It's not a place for beauty. Other sharp instruments, don't do it. So costly things, equipments. Tell some stop. So be careful. Don't do that. It should be a room which is heavy furniture, and you should see. And one important thing of that room should be, there should be 2 doors. Door out or door. Yes, this is very important. I am not. It's a very important, because when they are going to be violent, you cannot go out through this. You have to go through that. And you and another person can be in the room. You should have enough people outside to protect you when it becomes violent. You don't know when it is going to become violent. No one can predict when it's going to become violent. So you should be ready with these things before you break bad. That is why I kept death separately. Telling about malignancy is entirely different, but telling about death is entirely a different entity. So you should be ready for all these things. The room should be in such a manner so that you can convey. And suppose the patient is dead. Okay, fine. You have told them. But the patient is alive. Suppose the patient is alive and is gasping or is battling for his life. That is a different thing. You can tell him that, see, he's in the ICU, he's intubated, he's on ventilator. We are doing our best. We can pacify him. We can take him to that room. We can show him the ICU, 1 or 2 relatives, not the entire people. Most of the casualties, I've been talking about violence. I've been telling that every hospital, suppose in Kannur town, all hospitals should have a uniform pattern of restricting people entering into the casualty. Or accident, I have seen in many hospitals, or accident victim and a jeep load of people will come, especially at night. All of them will be drunk. Ellarku patient കാണണം. ഈ ഡോക്ടർ നോക്കുന്നതിന് നടുക്ക് ഈ പേഷ്യന്റ് എല്ലാവർക്കും കാണണം, എല്ലാവർക്കും because they are drunk. So you should be able to restrict people. So these are things. So when you show them the ICU, consider this is the patient. Slowly it will sink into their mind. And then when the patient dies, it is this senior doctor who has talked to them should be telling them, yes, the patient might be. So these are things which we won't have on a daily basis, people dying. But definitely whenever it happens, we should be taking the responsibility of informing the patient, relatives, sorry. And if the patient is in ICU, the patient is bad, we should be giving special care to that patient, telling you should, suppose, or an accident victim, so that the staff should be telling them or giving them an update. They are agitated, they are scared. Our relatives are ICU ICU. So that irritates them. You tell them at least 1 hour patient status improve. These are things which they should. But very often, news they'll keep knocking. One relative comes, he'll knock the ICU door. I think you must have all experience. I don't have to tell that. This is the nursing staff will get violent. They should start. These are things which happen. So when the patient dies, all that reaction comes. And as I said, how you inform the patient. Finally, if after suppose the patient has been in coma for a long time, you can tell them that this coma, the patient didn't have any pain. See, you can satisfy. You can tell them in a soothing way. They had a painless death. You don't. Death is a very sad thing, but you can pacify them. And now when the news is conveyed, they will cry, they'll howl, so you allow them to let the news sink, let them take some time, and then slowly talk to them about what, as I said before, I'm not repeating the things, how you talk to them and all. And okay, then they, as I said, deep coma and all. Okay, finally, when you're bringing the body outside, you're going to give the body. He must have a lot of gadgets or tubes written down. Remove all those tubes, clean the blood if there is blood, secretion, saliva, everything. All the should very presentable. If you have a comb is there also. Bleeding at blood, it should not be disfigured. It should be looking as pleasant as possible. That is a responsibility. Wrap them up in just the face being exposed. These are things which goes a long way. You have to respect the dead. This is very important. Respect the dead in the I was surprised. Like I go to the various colleges in the north to talk on ethics. I was surprised. Nammal anatomy hall, we used to go there. You know how the anatomy hall was. Everyone used to do whatever thing they want on that. But I was surprised. Nowadays, students have to, I don't know if it's there in Kerala, but definitely in some states like Maharashtra, Gujarat, and all, they take oath. They take oath on the cadaver. And I asked them, why do you take oath? The explanation is, they are our silent teachers. Yes, they are our silent teachers. That is the explanation I got. I said, great. Because you all know how we are behaving with the cadavers. But that is true. So we should always respect the dead. So when you give the body to the patient, you should be all the things, all should be wiped and clean. And there will be a lot of other procedures which the family have to go through. Death certificate. If there is a postmortem required, you have to help the patient get the postmortem done. All the procedures for the postmortem. Sometimes they may refuse. You have to convince them the need, especially if you do not know the unknown cause. You do not know the cause of the death. Just because the patient has said that I don't want a postmortem, you don't. You have to inform the police if there is, because there may be homicide. You do not know. It may not be suicide. So it is very important that you convince the patient, you inform the police. These are things which, say sometimes they just refuse. Sometimes people will say, some doctors have told me, I insist postmortem case. That explanation they have given me, people have told me that, but that is not the fact, because you have a reason why the patient died. You should know. Later, if they give the case, what you have no proof. So, or you have to get it written. Some people don't do it. You have to get it written from that they have refused postmortem. But then that is a different entity, a very controversial thing. And mortuary. See, when the patient is being taken to the mortuary, the doctor has a responsibility. Very often the doctors are not mortuary. But I insist, I tell doctors, you have a responsibility seeing that it is tagged properly, the pair proper, number. So otherwise you have, during COVID time, number of dead bodies were exchanged. Some they have been cremated. Some have to be buried. They have been cremated. Those who have to be cremated have been buried. That is very. These are religious things which people will not tolerate. So it is a responsibility of the doctors also to ensure that the mortuary and if it is properly tagged and properly, there's a protocol. There should be protocol. Each hospital should have protocol on how you handle dead bodies, how it goes to the mortuary, how it is released from the mortuary. Then a protocol. These should be a checklist. Otherwise, you cannot pinpoint where the fault is. You have to make some people responsible, whoever has done it. So these are things which we should be careful. And after the patient is left, or after the dead body has been carried, or after you have explained, I request my dear friends, don't rush to the OT or to the OP. You sit down. You relax at least for 5 minutes, because it's quite, it's quite tough, especially after explaining a death. You take your time. You cool yourself. It's a request from mine, because these are things which affect a doctor's health. 5 minutes is not going to do anything. No big harm. You sit and relax, and then you can go to your OP. Finally, to conclude, I would say the task of breaking bad news is a testing ground for the entire range of our professional skills and abilities. If we do it badly, the patients or the family members may never forgive you. And if you do it well, they will never forget you. This is again by Robert Buckman. Thank you for your attention. If you have any queries, I'm willing to answer.
Thank you, Dr. Srikumar, for the very wonderful talk. Topics often sources.
It was an excellent presentation, and I'm having some experience in this, especially what you have mentioned. We have to give some time for the relation of their beliefs. It's like 2 days ago, one patient was taken to Medical College as a brought 2-year-old boy. The boy was taken by the grandfather in a 2-wheeler. Accidentally, some accident occurred and baby died. And it was a baby of 2 professionals. And that lady came to she can't digest that because it was infertility and all. She's out of focus. She rolled over the floor of the kitchen for more than 10 minutes. We did this, we gave some time, and as you mentioned, we do have some housing spaces there, and she cannot digest that because the hospital said that it is for further treatment, sent to Vasudevan, not a problem. So I think that the feeling of we have to give space or time for maintaining that feeling. Maybe the aggressive thing. That's just a facility.
Now, we will have session. I invite Farsa to get member to our guests.
Okay, yeah, emergency is supported there. Training district level training from down. So the country is I share can that we can do from here. ഒരു ബാച്ചിൽ 10 പേര് പങ്കെടുക്കണമെന്നാണ് ഉദ്ദേശം. നമ്മൾ എല്ലാ ബാച്ചിലും പേരാണ് അതിലുണ്ടാകും. ശരി അവിടെയാണ് സംസാരിച്ച് നമ്മൾ ഒരു സന്ധ്യ മോർണിംഗിൽ ചെയ്യാൻ പറയും. സന്ധ്യ ഫ്രീ ഉണ്ടാവും. സന്ധ്യ
Good evening to all. Breaking bad news is always a difficult task. It is a fine balance between empathy and clarity of communication. I was always reminded of a few things whenever we talk about breaking bad news. One thing is grief reaction. Sir has briefly explained that. Elizabeth Kubler-Ross described that cascade of reaction to any bad news. First, we have denial, then anger, then bargaining, then depression, and at last there is expectation. I think this should be taught to every medical student, every professional. Every medical professional should know this cascade of reaction. So as Sulfi sir told, there was one incident. The mother was actually she was in a denial mode first. This topic is a, as I told, is a fine balance between empathy and clarity of communication. Srikumar Vasudevan sir illustrated every aspect, every nuances of this topic very well. On behalf of IMA Kannur, we are grateful to you, sir. Thank you, sir. And I express my sincere thanks to all the members who attended this meeting. Thank you.
For